Hello, everyone. My name is Kendra Mickens, and I'm going to be presenting Chapter 53 to you all. It's going to be drugs affecting uterine motility. So let's get started. When we look at it, we're going to actually go through a couple learning objectives. You can see we're going to identify core drug knowledge about the different drugs. We're going to identify core patient variables. We're also going to look at the interaction between core drug knowledge to the core patient variables. We should be able to generate a nursing plan of care regarding these medications, describe nursing interventions to maximize therapeutic effects, and also we should be able to determine some key points for the patient and family education for drugs that affect uterine motility. When we look at the classification of the medications, we're actually going to be looking at medications that actually either start or stop labor. So when we look at this, we actually have to discuss a couple things about pregnancy and how labor progresses. So when we look at it, pregnancy usually follows a set timeline of events. Actually, as you can see, contractions usually start around 28 to 42 weeks, excuse me. At times, this does not occur. So there are times when women will not go and start labor as they usually would. And when that happens, typically we may have to do something called induce their labor. And if you look here, we see that when a woman is induced, it is when labor is initiated by use of medications. There are also times where women will go into labor on their own naturally, but for whatever reason, that labor then slows down, and you can see the next term that we're going to learn is augment. That's a term we use when women actually go into labor on their own, but for a reason, sometimes we don't really know what slows down their labor, but we can then use some of the same medications that we use to start a woman who's not gone into labor to actually augment her labor so that we can get her back on a regular pattern. Now, on the flip side of that, in this chapter, we're also going to be talking about women who go into labor too soon. So you see that third term there is going to be preterm labor, and that's labor that occurs after 20 weeks, yet prior to 37 weeks when a woman would be considered full term past 38 weeks. So as you can see in this chapter, we will explore the classifications of medication used to induce augment labor, or the classifications of medications then used to stop labor. So again, really what we're going to be looking at in this chapter is a classification of medications called oxytocics, versus tocolytics. And when we look at it, oxytocics are medications that stimulate the uterus. So you can see they're used to initiate or augment a contraction pattern of labor. And then on the complete opposite side, we have tocolytics. And we see that tocolytics are used as uterine relaxants. They're used to stop labor or contractions that occur typically before the completion of the 37th week of labor. And again, that is because typically past 38 weeks, we're fine with women being in labor. It's actually to be expected. So you see again, the medications in this chapter will fall into one of these two classifications. And again, oxytocics help labor progress. Tocolytics are then going to slow or stop their labor. So let's look at some of the medications that fall within these classifications. So one of the main medications we're going to talk about, you see under oxytocics, we have this oxytocin. And then we also have this ergonavine maleate. We have methylergonavin, also known as Methergin. We have this carboprose, this dinoprotone, and misoprostol. And then on the tocolytics, we have terbutaline, ratitidine, otisabin, we have calcium channel blockers, indomethacin, and magnesium sulfate. And actually, this is something that I've also provided a handout for the students for. So we can look at it and you'll see it summarized in the handout for the students as well. Now, when you look at the medications from the previous slide, some of those medications may actually seem a little familiar. When you look at a medication like misoprostol, it has been used to treat peptic ulcers. Medications such as indomethacin is an NSAID, which has actually various implications and will not be used as an analgesic in this chapter. And you're going to learn that some of these familiar medications, because they fall under different classifications that you're familiar with, you're actually going to find that in pregnancy, they're used for very different reasons. Another one is calcium channel blockers, which we know are typically traditionally used to treat hypertension, but again, that will not be the implication for them in this chapter. Then we have magnesium sulfate that we're going to talk more about. It's a well-known electrolyte, and you'll see that principles regarding the effects of magnesium on the body will better explain how this actual electrolyte is going to apply for uses in a woman's uterus. So let's look a little at the pathophysiology. So there are times when labor does not start spontaneously after 38 weeks. And you can see it can slow after labor has occurred and may again need to be initiated. And that's that augmentation that we talked about. So uterine function can proceed abnormally, causing failure of labor to occur or failure of labor to progress. And a lot of times we don't always know, but when we look at it, there are two main categories of obstetric situations that require drug administration to initiate the onset of contractions. When we look at those, when labor is induced too early, the newborn may be experiencing respiratory complications. So we can't induce everybody. We really have to look and make sure that the benefits of induction are going to outweigh the risks. So again, when we look at this, in order to minimize the complications from prematurity, elective inductions for non-medical reasons should not be performed prior to 39 weeks of gestation, unless it is a medical emergency. So again, this is for elective inductions, no complications, no indication for early delivery. And again, the reason for that is typically the lungs do not fully mature until the end of the pregnancy, closer to the mother reaching her 37th week or more closer to becoming term. So when we look at the induction of labor, why would we actually induce a woman? So there are various reasons why labor may be induced. Indications for induction are centered around treatment of either a maternal or fetal complication. So when we look at these, what are some of these specific maternal and fetal conditions? Well, if we look at the slide here, it could be gestational or chronic hypertension, post-term gestation, so they've gone past the 41 to 42 weeks, a condition called preeclampsia or more severe eclampsia, when women who are pregnant start experiencing seizures related to high blood pressures. There is a premature rupture of membranes, also known as PROM. And then we have PROM near term with pulmonary maturity. And then also the severe intrauterine growth restriction, also known as IUGR. And as you can see, I'm going to provide another handout to the students that pretty much summarizes again these reasons for induction of labor. So when we're actually going to decide to induce a woman, there are a couple different factors that we have to look at. Physicians often have to weigh the induction for vaginal delivery versus a cesarean section. And here's the thing, a lot of times we'll find that with pregnant women, everyone's not a candidate for an induction, and we actually have some assistance in figuring that out. And that is going to be this Bishop scoring that we're looking at here. Because again, every woman may not be favorable for an induction. So when we look at it, the cervix is often assessed using this Bishop scoring to help the provider in predicting if an induction of labor will be successful. And when we look at the Bishop scoring, we see before induction, the fetus is assessed for maturity, again, to make sure that the lungs will be mature, and that hopefully will indicate that the baby will have less complications as it tries to adapt to extrauterine life. And then for seeing if mom will actually be successful if she is induced, you see the Bishop scoring scale here is used to assist in predicting if mom will be able to actually have labor and go through the process. Because if it appears that she does not have a favorable Bishop score, then in that case, she will end up with a cesarean section. So you see the Bishop score actually consists of 5 assessment parameters. We're going to look at cervical dilatation, cervical effacement, fetal station, cervical consistency, as well as cervical position. If any of these things are considered not favorable, typically when we're looking at the scoring system, if the score isn't high enough, then it will then be deemed, since we at this time are saying the baby does need to be delivered, or that mom has, again, some condition that says that the risk of her staying pregnant actually outweighs any risk that would be incurred if the baby were born sooner. Again, with this being said, we want to know, we don't want to put a woman into labor unnecessarily. And then again, we don't want to have a woman start contracting if she's not going to have a vaginal delivery. So again, ultimately, Bishop scoring is to figure out if she will be able to have a vaginal delivery. So let's look more into these oxytocics. So when we look at it, an oxytocin drug are synthetic forms of endogenous posterior pituitary hormone, in particular oxytocin. And so we see they produce uterine contractions and milk ejection from breastfeeding. And we'll see that we're going to talk more about the prototype of this particular classification of drug, which is actually oxytocin, also known as Pitocin. So far, we've talked about this medication being used to initiate induce or augment labor. But another thing we'll talk about a little bit as we learn more about this medication is it can also be used postpartum to help control bleeding. So let's talk more about this core drug knowledge related to oxytocin or Pitocin. So when we look at the pharmacotherapeutics, we see that oxytocin is considered actually a high alert medication because it has substantial implications for patient safety. When we look at this medication, it again can be used to not only induce labor, but augment labor for a woman who has gone into labor spontaneously on her own, and it can be used to assist with abortions as well and complications of abortions. When we look at the pharmacokinetics, onset of action is almost immediate after IV administration, has a plasma half-life of 1 to 6 minutes, and a steady state plasma levels that are reached in approximately 40 minutes with continuous IV infusion. So when we look at the pharmacodynamics, it stimulates uterine contractions, and again, the milk let down for breasts as well. So again, this is sometimes something that we also use for women when we perform something called a contraction stress test. They can actually either be administered a medication like oxytocin, or again, as we look at this relationship with the milk let down for breastfeeding, we can also have women have nipple stimulation, because that again is how that hormone is going to be released. And another, again, therapeutic reason why we can use it is to treat incomplete or inevitable spontaneous abortions, as well as helping women who are experiencing bleeding after they have delivered get control of that bleeding, because again, it does stimulate contractions of the uterus, which will actually help control their bleeding. So, like many medications, oxytocin is not for everyone. So when we look at it, there are going to be some contraindications and precautions regarding this medication. So essentially, one of the #1 reasons why we would not use this medication is if a C-section is indicated for the safe delivery of the baby. So in that case, again, oxytocin would not be used. Oxytocin is, if you think about it, a medication to make a woman contract. So if it's a contraindication for her to contract or to have a vaginal delivery, then it's going to be a contraindication for oxytocin. So let's look at a couple of these. We have cephalopelvic disproportion, or CPD. Essentially, the head of the baby is not going to fit through the pelvis. We also have unfavorable fetal positions or presentation. Those are going to be your babies that are in a transverse lie where she would not have a vaginal delivery. Some breech presentations. All breech presentations are not an indication for a cesarean section, but some are. So it depends on the type of breech presentation. Of course, obstetric emergencies in which the benefit to risk ratio for each either mother or fetus favors cesarean section. So again, if time is of the essence and we don't have the time for her to go through the labor process for the baby to be born and we need a rapid delivery, that's going to always be a cesarean section. Of course, fetal distress without signs of imminent delivery. Anytime we feel like this baby is no longer tolerating the labor, then we wouldn't then, if for some reason her labor slowed down and we saw that the baby was tolerating the labor poorly, then augment the labor for her to continue. The decision would probably be made for her to have a cesarean section. Tachysystolic uterine patterns, and we're going to talk a little bit about that. If her uterus is already overstimulated, again, this is a medication that does stimulate her uterus. We wouldn't want to stimulate it anymore. And then contraindications to vaginal deliveries, and those include invasive cervical carcinoma. If the woman were to have active genital herpes, a woman can have a history of herpes, but if it is active, she can't have a vaginal delivery. If it's just a history with no active lesions, she can have a vaginal delivery. If there's a cord presentation or a cord prolapse, she's going to be a cesarean section. Or if she were to have a total placenta previa or a vas previa, any of those would be an indication for a cesarean section. So we wouldn't administer her oxytocin or pitocin to put her into labor. And then, of course, if she were hypersensitive to the medication, we would not want to give her any pitocin. So again, continuing with our core drug knowledge, there are also possible adverse effects that we may see. So when we look at it, adverse effects, typically when we're dealing with pregnant women, we always look at it from the standpoint of we're dealing with two patients. So these adverse effects could not only be on the mother, but as, the fetus as well. So when we look at some of these maternal adverse effects, it could be nausea, vomiting, the uterine toxicity, and then the cardiac arrhythmias. For the baby, it could be bradycardia, this premature ventricular contractions and other arrhythmias, impaired fetal oxygenation, permanent brain or CNS damage, and death. And that's going to be because of the excessive uterine motility. When we look at contraction patterns, a lot of times both mom and baby, need time to rest. Typically, there's decreased oxygenated blood flow to a baby during a contraction. So while mom, we can see, is physically resting in between contractions, please know that that baby that we can't see is also kind of recovering from a contraction. And when we look at this, a good indicator would be a low APGAR score at 5 minutes after birth, neonatal jaundice, and the retinal hemorrhage. And just to talk to you a little bit more about an APGAR score is usually assessed not just at 5 minutes, but at 1 and 5 minutes. And a baby with a good APGAR score at 1 minute, unfortunately, can quickly deteriorate, which is why we then reassess it at 5 minutes. So again, and typically APGAR score is letting us know how a baby is actually adapting to extrauterine life, It doesn't tell us how the baby is going to develop. It just lets us know whether or not this baby needs any resuscitation at this 1 and 5 minutes. So again, sometimes the effects of the medication, because again, if the baby were overstimulated with the contractions and had some of these adverse effects, we may see the baby initially at 1 minute be okay and struggle at 5 minutes to continue to adapt to this extrauterine life. So again, if that uterus is overstimulated with oxytocin, there is a possibility that that baby will show signs of distress after it's born. And then when we look at the drug interactions, we have these medications, these sympathomimetic drugs that stimulate the sympathetic nervous system, can increase the vasopressor effect, leading to possible postpartum hypertension. So that's something we definitely have to monitor for. So when we look at oxytocin in summary, and so this is ending pretty much this section on the medications that stimulate labor or that we use to then augment or reintroduce labor to a woman whose labor has slowed down. We again see that it's used to induce or augment labor. Major contraindications are, again, conditions that we already know require a C-section, where this woman is not intended to have a vaginal delivery. Also, if there's hypermotility or stimulation of the uterus. The most common adverse effects can affect the mother or the fetus. Most serious adverse effects maternal-wise are going to be things like uterine rupture, water intoxication, which is uncommon, but can happen. Fetal adverse effects are going to be things like fetal demise, hypoxia, permanent brain damage, and then possibly death. So maximizing therapeutic effects, we want to administer when the cervix is ripened. And then minimizing adverse effects, we want to assess the mother and fetus carefully throughout therapy. For adverse effects and poor fetal tolerance, again, we have 2 patients, so we're going to have to monitor both of them. And then most important, patient education is going to be the purpose of the drug, rationale, and frequent assessment. This medication, again, is typically only going to be given to women who are supposed to be in labor, typically, unless it is an emergency where we feel like she could tolerate labor and does not require a cesarean section. So typically, it's going to be used in the 3rd trimester of pregnancy. There is a patient safety alert because oxytocin can cause, again, maternal and fetal death, and most commonly associated with administration of too much of this medication. So we've already talked about some of those adverse effects. And then when we want to maximize the therapeutic effects, again, we need to make sure that we titrate the dose upward slowly so that we can, again, monitor mom as well as baby in regard to minimizing effects. If ever you feel like the baby is showing signs of distress, or when you're looking at the mother's contraction pattern, the pattern indicates that she has been hyperstimulated, the first thing we do is stop the Pitocin. We're going to do a couple other interventions, getting mother oxygen, possibly turning her side, changing her fluids. But the very first thing we're going to always do is stop the Pitocin. Now, moving on from the prototype, there are a couple different medications that are similar to oxytocin, but are not exactly the same. One of these medications is Methergine, and we see it acts directly on the smooth muscle of the uterus, which shortens the third stage of labor and reduces blood loss. A lot of times, Methergine is actually given postpartum to help with postpartum hemorrhage. And you see, this is a medication that can actually be given IM or PO. When it's given IM after delivery of the placenta, it may also be administered after delivery of the anterior shoulder if full obstetric supervision is available. When it's given orally, it can be given 3 to 4 times a day, immediately postpartum, for a maximum of 1 week. And again, that's to manage postpartum hemorrhage. Again, you see I have starred here that we do have to use this medication very carefully in a woman who has blood pressure issues. A lot of times, if we feel like she had pregnancy-induced hypertension or was diagnosed as preeclamptic or eclamptic, they a lot of times will not use Methergine. As we see, hypertension sometimes with seizures or headache is the most common adverse effect. So if that was already a known condition that she had during pregnancy, because the risk is so high, in that case, a lot of times they'll determine that the benefits don't outweigh the risk in this case. So again, we look at her blood pressure, previous history. So Methergine is a medication that is not for everyone. Other adverse effects associated with this medication are hypotension, nausea and vomiting, dizziness, tinnitus, transient chest pain, the hematuria, thrombophlebitis, again with the water intoxication, hallucinations, leg cramps, nasal congestion, diarrhea, diaphoresis, palpitation, dyspnea. So then the signs of acute overdosage include, again, nausea and vomiting, abdominal pain, the numbness, tingling of the extremities, and again, I can't say it enough, the caution with the blood pressure because of the risk for increased blood pressure. When we look at these additional oxytocics, again, these differ. Methergine is more closely related, but these medications we're getting ready to talk about act in very different ways to stimulate labor. So when we look at the Hemabate, again, this is one that's actually used quite often to help control postpartum hemorrhage. So it's used to induce abortion in pregnancies at 13 to 20 weeks. But it can, again, also be used to control postpartum hemorrhage resulting from uterine atony, which is where that tone, again, when we're looking at the uterus, that is a muscle. A lot of times, if it was carrying a large baby or a large number of babies, or maybe was overstimulated during the labor process, a lot of times the tone can change and that uterus will not appropriately contract the way we need it to, which puts the woman at risk for heavy bleeding and hemorrhage. So again, we can use this sometimes after we tried the oxytocin and you see the IM preparations of Methergine. If that doesn't work, we still have something like Hemabate that we can try. And then when we're actually looking at the induction process, again, we can look at things like the Prepidil or the Cervidil we see here. So you see as a vaginal suppository, it's used to terminate pregnancies of 12 to 20 weeks. It's also used for evacuating the uterus and managing incomplete spontaneous abortion or intrauterine fetal death up to 28 weeks. When we look at the Misoprostol or the Cytotec, it's another synthetic PGE analog. And when we look at it, it produces uterine contractions. And we see an off-label use of it, which is actually how I've seen it used the most, is the off-label use, which is the effective use of using it to produce cervical ripening and initiating labor. So now we're actually ready to move on to the next section of this chapter, which is the complete opposite of everything we just discussed. We just talked about women who don't go into labor on time, or either they went into labor and it slowed down, or having issues with postpartum bleeding. Now we're going to talk about the women who actually go into labor way too soon. So let's talk about preterm labor a little bit. When we look at preterm labor, it's another obstetric event, usually requiring drug therapy. So if we look at it, if labor begins before the completion of the 37th week, drug therapy may be used to stop the uterine contractions and extend the pregnancy. In this case, a lot of times as well, because you'll also learn that as well as these medications may work, there are no promises with these medications. So sometimes a woman who goes into labor early cannot have her labor stop. Maybe her body does not react to the medication. So we equally have to then prepare for the birth of a baby that's going to be premature. And you see, the next thing we talk about is use of these corticosteroids, which are going to then be administered to improve the neonatal outcome, primarily by increasing lung maturity. So the effects of the corticosteroids is greatest if the pregnancy is prolonged for at least 24 hours and the benefits continue for at least 7 days. So again, if we can't completely stop a woman's labor with the use of these tocolytics that we're getting ready to talk about, at least a lot of times it will buy us just enough window of time to get these corticosteroids on board. So when we really look at the goal of tocolytic therapy, it is to really secure some additional time. We really just need some time. If we can buy more weeks, more time, that is great. But sometimes we just need the window to get the medications in. So again, the corticosteroids will reduce the risk for neonatal death, respiratory distress syndrome, and the intraventricular hemorrhage as a risk factor for cerebral palsy. Again, extending the pregnancy long enough for the corticosteroids to take effect is really paramount to improving the outcome of the unborn baby, which again, when we're talking about preterm labor, them not having mature lungs is a major issue for them and leads to a lot of additional complications. And when we talk about these corticosteroids, betamethasone is actually the most common corticosteroid that's used to accelerate the fetal lung maturity, therefore decreasing a lot of the complications associated with prematurity. So let's look at these classifications of medications. Tocolytics, which again are used to treat preterm labor. So when we look at these medications, they're drugs that inhibit uterine activity. They're used when true labor begins, again, after 20 weeks, yet before 34 weeks. So a little bit of why 20 weeks being the marker. What we also learn is typically a baby is not considered viable until after they're 20 weeks. So typically if a woman unfortunately were to go into labor before 20 weeks, none of the tocolytic therapy would be used because that baby would not be considered viable. But after 20 weeks, we can start using medications to see if we can stop her labor. So we see the use of tocolytic stops typically labor for 24 to 48 hours and occasionally up to 7 days. And again, that depends, on how her body reacts. We have beta agonists such as terbutaline, which we're going to talk about extensively, and ridodendron, and then also in the United States, this magnesium sulfate, which are used as tocolytics. And I can say typically it's either terbutaline or magnesium sulfate. When we look at the calcium channel blockers, especially nifedipine and Procardia, have been used and found to be effective in treating preterm labor as well. Then we also have these prostaglandin inhibitors such as indomethacin, which has been used as a tocolytic agent, and use of terbutaline to control preterm labor. It is an off-label use. Again, remember in the previous slide, we discussed what indomethacin is, and that's not primarily what the medication is used for. And we're going to see that, again, the prototype tocolytic medication is actually terbutaline, also known as breathing. So when we look at it, you previously heard me say that I primarily have seen terbutaline and magnesium sulfate used. Although ridodendron is listed here, it's actually not frequently used in the United States and is no longer included in some nursing drug books. When we look at the indomethacin, we have to be careful with that one. It actually has restricted use based on the mother's gestation. It is limited to use when she's less than 32 weeks due to the concern about premature closure of the fetal ductus arteriosus and the effects on amniotic fluid volume. And actually, it's a medication when a baby is born with a patent ductus arteriosus that they can then use to actually help with closure. So it does have some benefits, again, to the neonate as well. When we talk a little bit more about this terbutaline and breathing, let's look a little bit more at its core drug knowledge. Let's look at these pharmacotherapeutics. So, labeled uses of terbutaline include treatment of asthma, bronchospasm. Again, it's actually rarely used for that. Every time I've seen it, again, this course has been in this area, uses a tocolytic to stop a woman's labor, or at least slow down her labor long enough for her to get the corticosteroids on board. When we look at terbutaline, it has been used off-label to control preterm labor and pregnancies of 20 to 34 weeks. The drug must be, and again, must be administered in an inpatient setting. So this is no longer an outpatient option. And when terbutaline is administered to control preterm labor, it should be used concomitantly, again, with the corticosteroids. And terbutaline prolongs delivery long enough, again, for those corticosteroids to take effect. And when we look at the pharmacodynamics, not well known. There have been a lot of changes with terbutaline over the past couple years. When we look at the FDA's indications and label uses for the medication, it's actually restricted the use of terbutaline to a maximum of 48 to 72 hours. It can still be given either subcutaneously, which is what I've seen most often, or by IV. It used to be given PO as well, but most recently that is now contraindicated. So although in the past, prior to 2011, it was also given in pill form, but now no longer is. And when we look at it, although the goal of terbutaline use is to stop or slow down labor, there's a chance that the labor will continue, as I alluded to earlier. It just kind of depends on how the mother's body reacts to the medication. So again, now let's look at some of the contraindications and precautions as it relates to terbutaline. Again, like most medications, it's not for everyone. So when you look at it, terbutaline is contraindicated before the 20th week of pregnancy because, again, the baby wouldn't be considered viable. So we wouldn't use it prior to 20 weeks. Then there are conditions in which continuing the pregnancy is hazardous to the mother. So again, we wouldn't want to prolong it. And what you may notice a little bit is some of these are going to be similar to the reasons why we would go ahead and induce her labor. So antepartum hemorrhage that requires immediate delivery, eclampsia and severe preeclampsia, intrauterine fetal death. Again, we're not going to stop her labor. If her body recognizes this and she goes into labor, we're not going to stop it. There's something called chorioamnionitis, which is inflammation of the amniotic membranes, maternal cardiac disease, pulmonary hypertension, and then maternal hyperthyroidism and uncontrolled maternal diabetes mellitus. We also then, of course, if they are hypersensitive to any component of any of the medications, then we wouldn't want to give it as well. So when we look at a medication like terbutaline as well, when we look at the precautions, it also now carries a black box warning and should not be used for longer than 48 to 72 hours. And again, is contraindicated recently, at least as of 2011, for oral use. Additional contraindications for using terbutaline will be hypovolemia, cardiac arrhythmias associated with tachycardia or digitalis toxicity, uncontrolled hypertension, and pheochromocytoma, which is a hypertension-producing tumor of the adrenal glands. Yeah, let's back up one here. So again, continuing with the core drug knowledge, let's look at these adverse effects. So it's a potent drug. And again, similar to the oxytocin, can have serious, even fatal effects. So adverse effects in women, again, and in fetus. So again, whenever we're talking about a pregnant woman, I want you to think about the fact that you have one patient you can see and at least one patient you can't see. So when we think about the adverse effects, I want you to think about adverse effects not only to mom, but again, also to baby. So when we look at some of these maternal adverse effects, you see I have underlined here tachycardia. It's actually one of the most common ones. They can also have palpitations, hypertension, cardiac arrhythmias, electrocardiographic changes, dyspnea, nervousness, tremor, and you see the list kind of goes on. Also, of course, typically heart and lungs go together. So then pulmonary edema, cerebral and myocardial ischemia, nausea and vomiting, and maternal death, unfortunately, has also occurred. So then when we look on the baby side, fetal and neonatal effects, increased fetal heart rate and neonatal hypoglycemia. And for this, there is an antidote, and that's going to be propranolol. And actually, that's explained a little bit more just below in the drug interaction. So additive effects may occur if terbutaline is administered with other beta stimulants, but on the complete adverse side, co-administration of terbutaline and beta blockers decreases the effectiveness of terbutaline. So you can see how that propranolol comes into effect there. When we're looking at these adverse effects, tachycardia, maternal and fetal, again, are the most common. And again, we see that most of these adverse effects, again, involve the heart. Also, it's important for you to know that patients often report feeling jittery, a little shaky, a little bit like they've taken speed or had a lot of caffeine a lot of times after they're administered terbutaline. And their pulse often will be greater than 100. So when we look at that, breathing is advised to be held for pulses greater than 100 or per the provider's orders. It just kind of depends on how well they know the patient, how well they've seen this patient adjust the medication. So you may get a rare order where it's not held if it's over 100. But typically, again, we always take a woman's pulse prior to giving her her next dose of terbutaline and may hold it if that pulse is greater than 100. And again, we cannot forget in instances of an overdose, we want to make sure that we have propranolol readily available. So let's look at this summary here. So again, when we look at it, it's actually going to be an off-label use, used to control preterm labor again after 20 weeks. It is a beta-2 receptor agonist. And then the antidote again is going to be propranolol. Most common adverse effect is going to be maternal and fetal tachycardia, maternal palpitations, cardiac arrhythmias, and tremors. And most serious adverse effects, multiple serious cardiovascular problems, with the severity ranging all the way up to death. And then most important, patient education, drugs to control preterm labor, help buy time for other drug therapy to have an effect in preventing complications in the newborn. So we just have to explain to them why it's important. Again, when a woman has never felt the side effects of a medication, it can be very scary, again, because this medication will make her feel a little jittery. So again, educating her on the importance of the medication. And again, remembering that black box warning for the limited use of time, only in a hospital setting, not to be used in an outpatient setting, not to be administered orally. And again, per doctor's orders, but typically held if her pulse is greater than 100. So let's look at a actually very different tocolytic. Again, the most common ones I've seen are the terbutaline, and now the next most common one I've seen uses tocolytic is actually the magnesium sulfate. And you see, this is that electrolyte that we were talking about earlier, which is given actually IM or IV. So when we look at it, it's a trace mineral involved in many chemical reactions in the body. So going back to fluids and electrolytes, we know this is electrolyte that we definitely will see in a CMP. So when we look at it, magnesium sulfate acts as a CNS and muscular depressant and relaxes smooth muscle and decreases blood pressure, possibly related to its antagonistic effects on calcium, which prevents calcium influx into the cells for cellular contraction. So also think about the fact that we talk about a lot of calcium channel blockers for blood pressure medications. So when we look at this, calcium gluconate is going to be the antidote for magnesium sulfate. Typically on any unit where there is magnesium sulfate, calcium gluconate is going to be readily available. So when we look at it, magnesium sulfate may also cause adverse effects on the mother, such as headache, hyperreflexia, and that's hyporeflexia, weakness, thirst, flushing, burning at the infusion site is a common complaint. Again, they're very, very hot a lot of times with that flush feeling. And when we look at it, you can understand when we talk about how it is a CNS and muscular depressant, how this is going to have this relaxing effect we want on the uterus if she's contracting. But it's actually also, again, frequently used to prevent seizures in women who are preeclamptic, hoping to prevent them from becoming eclamptic, which is at a point that she has a seizure. So again, it's that relaxing effects on these muscles. So primary use in pregnancy is typically either going to be as a tocolytic to relax that uterus, or again to what we call raise her threshold for having a seizure. As with terbutaline, again, this is a off-label use, but frequently used in the United States. And this is another one that actually does also carry the risk of fetal death. So have to monitor mommy, have to monitor baby. So when we look at magnesium sulfate, it's one that we actually typically will draw routine magnesium levels on. While a woman is receiving magnesium therapy, she may get her magnesium levels drawn every 4 hours, every 6 hours, every 12 hours. It just kind of depends on what is ordered for her. And as you can see, when we're looking at the therapeutic level of magnesium is above what's considered normal. So it's very common for the laboratory to call the unit with a panic magnesium level, although we actually on the floor know it's actually a therapeutic level for either tocolytic therapy, or you can see for preeclampsia, eclampsia, convulsion therapy. So while it's higher than normal, it's considered, again, therapeutic. The 4 to 7 is therapeutic for magnesium therapy for treatment, as we're either preventing her from having contractions or hopefully preventing her from having a seizure. But again, you can see as these levels then rise, again, if we think about the muscles relaxing, and that's all the muscles, you see now they're at great risk for respiratory depression. So at levels of 13 to 15, respiratory paralysis. Again, you can see now cardiac conduction could be altered at levels of 16 to 25, and then complete cardiac arrest at 25. So again, due to these risk factors that's associated with it, although typically they're going to get the levels drawn at minimum at least every 6 hours, you have to have the calcium gluconate. We have to have that readily available in case a woman does end up with toxic levels of magnesium in her system. So when we look at it, there are some more additional tocolytics that are different from terbutaline. So again, this is where we get into the calcium channel blockers. So medications like the nifedipine, which again can be given for blood pressure, because again, women will have blood pressure issues in pregnancy, but most often when it's given, again, it's actually given as a tocolytic. So a lot of times it's very difficult to kind of wrap your brain around that. But in this case, this is actually a blood pressure medication that is actually being given for its tocolytic effects. So we see these calcium channel blockers do not induce the same adverse effects in the mother or infant as the beta agonist. So a lot of doctors like these. It's a blood pressure medication, so as long as her blood pressure isn't super low, it's a pretty good alternative. It is actually. Research has shown that calcium channel blockers like nifedipine are as effective, if not more effective, in preventing preterm labor as the more traditionally used beta agonists like terbutaline. So this was pretty popular. And then again, when we look at the indomethacin that we touched on a little bit earlier, it is an NSAID, which typically women don't get a lot of NSAID use when they're pregnant. They're typically not told to take ibuprofen. They're typically told they can take things like Tylenol and still not excessive amounts of it. But this is an NSAID, and it's used to actually suppress uterine activity. But again, remember, we do have that window of time that we can use it. It's only typically used prior to the 32 weeks. Again, because of the risk of it prematurely closing that ductus arteriosus. So there's a window of time that we can use it, but also shown to be effective when we're looking at stopping premature labor. And you see stopping that premature labor for 48 hours up to the 7 days. So unfortunately, ladies, we've come to pretty much the end of this chapter. So I hope that you have learned quite a bit, again, in how we either start, augment, or augment labor, as well as how we control bleeding after delivery. And then on the complete reverse side of that, how we help women who go into labor too soon. So again, drug therapy may be used when labor does not occur at the correct time, either late or too early. It could be either way. And we know that the oxytocin is given by IV drip infusion to initiate or augment labor, also used to control postpartum bleeding or hemorrhage. And an infusion of the oxytocin must be stopped if we see that tachysystole occurs, because again, we don't want to overstimulate her. We really don't. And for that, again, we know it's not just risk for mom if she's overstimulated. Again, we've also discussed the risk to the fetus. When we look at the tocolytic drugs, they're used to stop preterm labor. And again, we know that's really labor that occurs after 20 weeks. Anything prior to that is too soon. So when we look at it, tocolytic drugs do help prolong labor. Again, long enough at minimum, we hope, to get the corticosteroids on board if we feel like we're about to be dealing with a premature baby. And again, that is so corticosteroids like the betamethasone can be given so that we can get the lungs to accelerate and mature quickly. So terbutaline does decrease the intensity and frequency of uterine contraction. And again, we have to remember this and magnesium sulfate for both of those medications. It is actually an off-label use. And again, when we look at these tocolytics, the time frame in which they're used are typically limited to the 48 to 72 hours via injection or infusion in the inpatient setting. And again, we cannot ignore the serious risk factors associated with these possible maternal cardiovascular events and death. When we look at the chapter summary, which is continued, the magnesium sulfate is used again off-label, similar to the terbutaline, to stop preterm labor. And magnesium sulfate is a drug of choice to treat preeclampsia as well as seizures in eclamptic patients. And again, when we give it to preeclamptic women, we're hoping to prevent them from becoming eclamptic, raising that seizure threshold. When we look at the adverse effects, particularly respiratory depression, related to high concentrations of the drug in the blood. So again, the need to have that calcium gluconate on hand at all times, and then close monitoring of patients for signs of adverse effects is needed throughout the therapy. So let's see what we remember, ladies. I couldn't get this to go into the regular traditional slideshow form, so you're going to see the answers, but let's talk about it. So we have the nurse would question an order for oxytocin on which of the following patients. So we have a woman 39 weeks, 39.3 weeks pregnant whose labor has slowed down and contractions are ineffective. Then we have the woman who's 14.2 weeks pregnant, diagnosed with a missed abortion, a woman 41.5 weeks pregnant who has not gone into labor on her own, and a woman who's 38.5 weeks pregnant, diagnosed with a total placenta previa. And as we can see, the answer is going to be A. The nurse will question an order for oxytocin on which of the following. So it's excuse me, it's actually D. I'm looking at the A in A woman. So the answer is actually D, because if we look at it, again, the woman who's 39 weeks pregnant, she went into labor on her own and now it's slowed down. That's appropriate to use oxytocin. For the woman who's 14.2 weeks, who had a missed abortion, that's appropriate. It can help with the evacuation of the rest of the products of conception. When we look at the woman who's 41.5 weeks, I mean, ladies, let's help get this woman out of her misery. That would be an appropriate indication. But when we look at D, this woman has a total placenta previa. So for this woman, it is contraindicated, as we can see, because she's supposed to get a cesarean section. It's actually a contraindication, so we would not want to put this woman in labor in this situation. The next question, a nurse is aware that a severely preeclamptic patient is at risk for uncommon adverse reaction related to oxytocin administration. We have the water intoxication, nausea and vomiting, cardiac arrhythmias, and tachysystole of the uterus. So the keywords here, we can see the answer is actually A, water intoxication, which again, although very rare when we look at it, water intoxication, less common adverse reaction, but potentially fatal, of course. And the risk factors for the water intoxication, the key word here is that this woman was preeclamptic. And we see that when we look at these people, they're receiving large amounts of fluids, IV or oral, or patients with impaired renal excretion, such as a patient with severe preeclampsia. So we have the nurses caring for a patient whose labor is being augmented with oxytocin. The contractions are occurring every 2 minutes, lasting 100 seconds with an internal pressure of 100 millimeters per mercury. So when we look at it, the nurse's priority intervention would be, we have administer 10 liters of oxygen via face mask, turn the patient on her side, stop the oxytocin, and prepare the patient for cesarean section. So again, we see the answer here is actually C, stop the oxytocin. And again, when we look at this one, this is one where we may do everything in this scenario. But the information that was given lets you know that her uterus, is overstimulated. So what are we going to do? we're going to stop what's causing that overstimulation first, and that's going to be the oxytocin. We are probably absolutely going to turn her on her side, absolutely give her some oxygen. And if for some reason we can't stop this, she may end up with a cesarean section. But the key word here was priority intervention. So let's stop the medication that is causing the problems. Then we have question number 4. The nurse is preparing to administer terbutaline to her patient. Prior to administering the medication, it is most important that the nurse assess. We have patient's respirations, patient's blood pressure, patient's pulse, patient's O2 saturation. And the answer, of course, is C, the patient's pulse. Again, this is a medication that we would actually typically hold unless we have some other specific instructions by a doctor if her pulse was 100 greater than 100. So it's again important to monitor the patient's pulse due to the risk of tachycardia, palpitations, and cardiac arrhythmias. And last one, ladies, the nurse is aware that magnesium sulfate is used for the prevention of what maternal condition? So we have placenta previa, eclampsia, gestational diabetes, gestational hypertension. And although not quite on the same vein of the topic that we were discussing, we did learn that the answer is B, eclampsia, and that in addition to being a tocolytic, the benefits of magnesium sulfate is that it can be administered to increase the risk of seizure activity related to high blood pressure in pregnancy. Well, ladies, that is my presentation. And I pretty much just used the book for our PowerPoint presentation here. I hope that you were able to learn something and that I didn't bore you and that you enjoyed my presentation. Thank you, ladies.